Hi, it's Dr. Jo here. I'm a working doctor in New Zealand. I'm a GP, and today I thought I'd let you in on what doctors really want to know about your pain symptoms. So when I have a patient come in about their pain, it doesn't really matter what pain they've got. I will always work through the same framework in my mind, and it's a framework I've used since med school, which is over 25 years ago now, and it stood me in good stead. I haven't really used any other framework in my head, so I'd love to hear some ideas from other doctors actually, but this works well for me. So it's a mnemonic. I use the mnemonic Lost War and location, or what I'll do is I'll let you know what Lost War stands for. There's one extra thing at the end, which I haven't worked into the mnemonic yet, but I'll talk through each part of the symptom in more detail. But Lost War is location, onset, severity, timing, worsening factors, alleviating factors, and radiation. So location, so again, it doesn't really matter what the pain is exactly. I want to know where it is, and often just pointing is very helpful, especially as sometimes people say, oh, I've got kidney pain, and then point to, you sort of say, oh, where do you mean? And they point to somewhere that's nowhere near their kidney. And that's totally fine, because I don't expect the patient to have an in-depth knowledge about their own anatomy, because that's my job. But so pointing is often very helpful, and if you want to use expressive hand gestures to sort of point to where it is, or sort of this kind of thing, that can be very helpful. So location, yes, is it a pinpoint pain? Is it a general pain over the area? So just give me a sense of where the pain actually is. Onset, by that I mean when it comes on, is the pain sudden onset or a gradual onset? So does it have a sudden spike, or does it come on more gradually? And again, you can be specific about the time frame. Oh, it comes on gradually over 2 or 3 hours to its maximum, or you can say, oh, within 2 seconds it's there. So that's helpful as well. S is for severity. So severity, you can just use words, but so you can say, oh, it's not too bad, or it's actually really severe, or but what I always then try and gauge with the patient is I do use the 0 to 10, try and get them to put it on a scale of 0 to 10. And often patients seem a bit concerned about this, because they seem to think, well, if I say a 4 out of 10, but really I know what a 10 out of 10 is. If I say this is 4 out of 10, will they think that the pain's not that bad? So what I always, doctors, we tend to say, can you put your pain on a scale of 0 to 10? If 0 is no pain and 10 out of 10 is the worst pain you've ever had. So actually, I try and make a point that it's actually your own personal pain scale. And it can be helpful to know what the 10 out of 10 was. Was it childbirth, a broken leg, or whatever? It kind of puts it in perspective. But generally speaking, I want to know what this pain is for you right now, based on your experience of pain. So yeah, if for you the pain is 2 out of 10, but it's still actually pretty bad, I'm going to get a rough idea using this scale, so we do take pain seriously. And a low score on that scale, if 10 out of 10 was, I've been crushed by a huge tree when I was a little boy or something, we kind of get the picture. So trust us to trust you that we take your scale seriously. And along with that, I'm going to add in an extra one here, but along with that severity is, what does it stop you doing? So again, that just gives us like a qualitative. So the scale is like a quantitative scale, and then the qualitative is, I can't run around, or I can't walk, or it stops me doing the housework, or I can't run around and play soccer or whatever, football, I should say. So yes, in terms of your function, what's it stopping you doing? And it may not stop you doing anything, but you can say it's really sore when I have to go to work all day and it's actually really sore. It gives us an idea of how limiting it is for you. Actually, that reminded me about something else with the pain scale is what I find really useful about that is if I see the person down the track. So if I see you next week, I can ask you how's the pain at the moment, and on your scale, and if you say, oh, it's 8 out of 10 now, it's got worse, doc, it's 8 out of 10, I can go, oh yeah, because last week you said it was a 4 out of 10, and they're like, yeah, it's literally twice as bad, it's 8 out of 10. It's just useful. That's what I find really useful about that pain scale, is kind of tracking the pain over time. But yeah, so we've got lost warts, we've got location, onset, severity, timing. T is for timing. So yeah, is it a constant pain or does it come and go? So by constant we mean like when you've got the onset, and then when it's there, what's it doing? Is it constant at the same level? You could say it's there all the time, but it doesn't, it's between a 4 and a 6, but something's there all the time. Never goes away. That's what we mean by constant. Coming and going literally means, it's there, it's not there, it's there, it's not there. And over what sort of time frame is that? Does it come and go every few minutes, or is it, during the course of the day it comes and goes a couple of times? So again, you can apply a time frame to those, that description as well. So sort of tied in with this, actually this is another extra thing that's not in the mnemonic, is the nature of the pain. So if you can describe for the doctor what the pain is like. So I always say, can you describe what the pain is like for you? So your experience of the pain is, is it a dull ache? Is it a sharp stab? Is it a, and you can use whatever words. It's really a description, like what does it feel like for you? And then the doctor, I might then kind of try and draw out a bit more information from what you have told me about the nature of the pain, because I'm trying to now work down a sort of diagnostic tree of what all the possibilities might be. So things like a colicky pain is where the pain kind of comes in waves, and I do this when I'm trying to describe to patients what I mean by colicky pain. I'm like, does it come and go in waves? Does it come and grab you and then ease off, and come and grab you and ease off? And again, it might be over different time spans, but so labor pains are colicky pains, gallstone pain can be colicky pain, kidney stone pain can be colicky pain. It's because generally it's something squeezing down onto something, is that sort of contraction type pain. Anyway, that's just one example. So if you can explain what the pain is like for your doctor, that will be quite helpful diagnostically. So I've digressed a bit, I've got off my own mnemonic, and that's kind of what happens in a consult. You don't get these questions coming out in a regimented fashion. It's really, they're not even in a logical order actually, but what I'm trying to do is in my head I'm like, okay, have I asked about that, have I asked about that? And during the course of the consultation with the patient, I'm making sure I'm extracting this information, make sure I've kind of got everything I need. So yeah, W is worsening factors, so things that make it worse or things that trigger the pain. So things that are particularly interesting are, does food, drink, movement, position, stress, yeah, and if it is food, any particular sort of food. So just trying to work out what might be making the pain worse. Or triggering it to come in the first place. A is for alleviating factors. So this could, again, it's quite often the opposite of the worsening factors. So lying still or moving around, is standing better than sitting, is nighttime better than daytime, is, yeah, and under alleviating I always ask about pain relief. So what are you finding helping? And they might say, a heat pack or that kind of thing, but sorry, I've just gone off on a tangent. brain's not really with it. Actually, that happens in a consult, but don't tell anyone. Brain sometimes goes off for a little wander. But yeah, back to it. So alleviating, yes, pain relief as in tablets usually is where I get to with that. So find out what you've already taken. And also if you can sort of remember the doses, or even bringing in the packets is really helpful, because then it's just one less thing you have to remember in the consult. You know, if a patient tells me they've taken a certain anti-inflammatory and I know it comes in 3 different doses, it would be really helpful to know what the dose was. Just gives us an idea of what's helping, what's not helping, and how we might be able to help you with prescription medications if that's what's required. So that can be helpful. And R is for radiation, last but not least. So radiation, where does it spread to, if at all? And actually that's can be tied in with the location. So, you know, does it go through to your back? Does it spread across the chest or the abdomen, or down into your legs, or down into your arm? Or you say, no, it's right there, you know. So it's either a spreading, the pain can spread at times. And again, that kind of leads to other questions like, what might bring that on? What triggers that? If you say, you know, it does spread down my arm sometimes, it's like, okay, what are yeah, again, you're into your whole lost war again. You're into, okay, what part of the arm? So location, you're like, how bad is it? And what's the nape? Is it pins and needles? Is it? So you work down the same kind of questions. So as you can see, doctors, it's kind of the same information, whatever the symptom in some ways. And certainly with pain, or physical symptoms like pain, it's quite often the same kind of questions that we want to know. So you get the idea. So is it pain itself, you know, what starts off as shoulder pain can get very, very detailed very, very quickly, which is often why consults take as long as they do, because trying to get all that information does take time, but it's worth doing, because often we've got a pretty good idea of what the diagnosis is after talking to you and getting the information. And then of course there's examination, which usually we're trying to just confirm what we're already suspecting, or sometimes we have no idea, and sort of you know, sometimes the examination is helpful or tells us what it's not. So it's, you know, medicine's always a challenge. And if I don't know by the end of all that, I do try and be honest with my patient, and my patients will know. If I don't know, I will say I don't know. I can say I don't know what it is, but I know it's actually probably not this, or I don't know for sure, but it's very likely to be this. I mean, medicine's an art, not a science. It's very hard sometimes to know exactly. Well, sometimes the diagnosis is obvious, and that's actually quite nice, but often quite rare. But yeah, so that's how I kind of work through a consultation that involves a pain symptom. Oh, I missed out something else. Associated symptoms. I must put that under A. So associated symptoms is things like, do you get short of breath? Do you trying to think, do you feel sick with the pain, vomiting? If it's abdominal pain, ask about things, you know, bowel habit, you know, bowel motions, bladder symptoms, all those things. Associated is anything else that might be kind of relevant that's going on. Well, actually, let the doctor decide what's relevant. If you can say what other symptoms are, kind of come along with the pain, or you think are associated with the pain, that's often super helpful. So yes, I hope that has helped a wee bit. If you're going into a consult involving a pain symptom, I hope your pain gets better soon. But yes, so do like and subscribe to my channel. I'm vlogging every day at the moment. This week I'm putting out a vlog every day about what I don't particularly know, but I'm hoping people find it useful. So far I've done I've done videos about consults and how to get the most out of consults. So I might just keep vlogging about that this week when certain things come to mind. I hope you have a good day, and I'll see you in the next one. See you later. Bye.